for 8 years where we're doing this almost every day. I've been doing it much longer than that, but in doing this day in, day out for that period of time, you start to see a lot of different types of cases, a lot of scenarios, and they're not in any textbook. And so a lot of the things that we'll talk about today are things that I've just run across over the years. And this is talking about just standard, all on four type cases, immediate load. And I'm going to call it all on four. All on four was a term that was coined, by a particular implant company, but it's almost like Xerox. Xerox invented copying, and now when you're talking about copying something, you say I'm going to Xerox something, or I'm going to make a copy. And all on four, even though it was invented by one particular company, they have it trademarked. We just use it so much that everyone knows what it means. So I'm going to refer to it as both things, but it's literally a verb at this point. So in our practice, we call this procedure dia arch. We have I'm in Texas, a very large Spanish population in Texas. Dia means day in Spanish, and dia arch is basically we're giving you a set of teeth in a day, and we're utilizing Norris Medical exclusive in our practice today. And I'm going to go through same day full arch implant rehabilitation, and I'm showing a number of cases literally over the past 10 years. And so you may see some different implant companies in there and different things, but I'm showing you the technique. I'm showing the style. I'm going to try to discuss my thought process behind a lot of these cases. And then at the end, I'll also show you, why I'm currently using Norris Medical today, as opposed to some other implant companies. So first of all, I want to start off telling you what dia arch is not, what all on four style cases are not, because in talking to a lot of dentists, and I used to get a lot of referrals, most were direct to public now, but when I used to work with dentists and get referrals, I would talk to them about these types of cases. And I found that there was a lot of confusion about these cases, because they'd say, oh yeah, I've done some of those cases before. And then they'd tell me what they were doing. And I said, well, that's not really an all on four type of case. That's really not a, immediate load type of case. And so, these cases are not four on the floor. I had this one doctor that would constantly call it a four on the floor. Floor on floor is what I had in my old 67 Mustang. It is not a one for all. That is something that we see in the movies, and it is not that. They are not snap-on dentures. I have a lot of dentists that describe these cases to me, and essentially what they're talking about are snap-on dentures. That is not what this is. These are not cases where we are extracting teeth, doing bone grafting, waiting for the bone to heal, coming back and placing implants at a later date. This is not what we're doing with these. With these cases, we are doing a minimum of 4 implants used to support an immediately loaded fixed prosthesis. And when I say immediately loaded in our office, typically that means within 2 hours. Now, I know some places will do it the next day. And if you want to consider it immediately loaded, I would say it needs to be probably within at least 48 hours. Otherwise, you're getting to a delayed load approach. Now, with this procedure, the posterior implants can be angled up to 45 degrees. And we're doing this for a number of reasons. Primarily, we're using it to avoid anatomic structures such as the maxillary sinus, the mental foramen, the inferior alveolar nerve. However, once you start to do a lot of these cases and you start to involve different types of implants, such as zygomatic implants, pterygoid implants, Vomers, piriform rims, all these different styles of implants, everything isn't going to fit in the same neat little box. But ideally, we're placing at least 4 implants and we're loading them, immediately. So we're going with immediate function and immediate load. So when patients come in seeking this treatment, they are wanting teeth on that same day, especially if you're advertising, if you're putting your clinic out as a full arch implant center. When patients are coming to see you, that is what they are expecting. They're expecting to leave that day with a set of teeth that they can utilize. And that becomes tough when you start seeing a lot of different types of cases, because some people have more bone loss than others. Some people have softer bone than others. Some people have a lot of infection compared to others. And one interesting thing I see is, we do a lot of consults and we have a lot of patients come through the door, and many times they will have seen other offices. And some of these people just have almost no bone. And I'm explaining things to them and how we would treat the case. And they say, oh, well, I went to this other place and they didn't tell me any of this. And I said, well, what did they tell you? And they said, oh, yeah, well, we can do it. I said, well, I don't know how they're planning on doing it because you don't have any bone. There's, and I've done thousands of these cases, so I really, am looking at these with the eye of, I don't want any problems a few years down the road or years down the road, because I have to deal with them. And I don't like to deal with problems. I like to go home and not hear my phone ring. And, so when we're designing these cases, we want to design them with the fewest problems in mind down the road. And by engineering them properly, we can avoid a lot of those problems. And so when we're talking with a standard all-on-X case, then what we're doing is taking out the teeth, putting in at least 4 implants. And you can see in this case, we have 4 Norris implants, and we have them angled to avoid the sinus. We have them angled to avoid the nerves. And then we're using these to provide immediate support for immediate load, immediate function. And so in the upper jaw, you can see that when we're placing these implants, typically what we're looking for is to angle and avoid the sinus. And in the lower jaw, when we're placing these, we're looking to avoid the nerve. And the nice thing is, because the nerve exits the bone at the middle foramen, we have this nice area called the chin. And what we tell a lot of patients is, if you have a chin, we can do your implants. And pretty much everyone has a chin. And I'd say within the past decade, there's only been maybe 2 patients that we weren't able to do a procedure for because they didn't have enough bone. And some of these people had so much bone losses, it's quite amazing. Literally, if they were to fall down, they were going to break their jaw because everything was so thin. But on average, almost anybody can get this procedure done as long as they have a chin. And in the maxilla, once you start doing more what we call exotic implants, the zygomatics, the pterygoids, fomers, piriform rims, then really there's almost no patient that you can't treat with this type of procedure. So, does this procedure work? Well, we know we have 20 years of published data on this procedure. The implant success rates for this procedure are typically over 98% when we do it in a all-on-4 style or immediate load, do a full arch immediate load method. Prosthetic success rates typically exceed 99%. And this is repeatable with different authors around the world, many, many different countries, and using many different restorative materials. So we know this works because this is being done all over. And it's been done for now at least 2 decades. And when we're talking to patients about this procedure, and I even had a patient just today ask me this because I worked today. And matter of fact, I did a surgery today and I put it in this lecture. So you will have a fresh surgery, probably a lecture with the freshest surgery, unless you're watching it live in a lecture, because I just did this just today, put it in the lecture, and you'll see it at the end of the procedure, at the end of the lecture. But when we're doing this, some patients will ask, well, how long is this going to last? And, they'll say, well, such and such office told me it's going to last a lifetime. And I said, well, truly, we can only talk about 20 years of published data, because the first studies for this type of procedure, were published in 2003. And those studies were based on cases that were done in 1998. And so we know that success rate on these are very high. And we know based on historical studies with other implants that the longevity of this is high. But really, if you're being honest with the patient, you need to refer to the 20 years of published data. And there's a number of studies out there. And if you become familiar with the lid on this, you can really educate your patients on what they can expect with this procedure if they take care of things after they have the procedure done with proper maintenance. So if we want to look at survival for this procedure, we have the typical single implant survival, but Malo has what he calls his Malo Clinic survival criteria. And this is specifically for these types of procedures. And for this, we're talking about an implant has fulfilled its purported function for support in reconstruction. The implant was stable when it was tested. There was no signs of persistent infection, no radiolucent areas around the implant. There was a good aesthetic outcome. And that could be very variable in different practitioners' eyes. Some people think something's aesthetic. Some people think something's not aesthetic. So that one, is up for debate there. And the implant allowed for construction of an implant-supported prosthesis that provided patient function and hygiene maintenance. And this is something when patients come in looking for this procedure, the majority of these patients are looking for function. Aesthetics is a side benefit. And, I had this asked to me yesterday in the clinic by some people that came to visit, and they were asking, what percentage of patients are coming for purely aesthetics versus function. And I said, really, it's a combination of everything, because when patients are looking for this procedure, occasionally you'll have somebody come by looking for something purely aesthetic. And, most of those times, those patients also have other issues. They have failing teeth, they have difficulty chewing, they have pain. So it's usually a combination of everything. And so when we're doing these procedures, we'd like to fulfill these Malo Clinic survival criteria because this is going to ensure that our implants, that our prosthesis are going to have a long-term good outcome and survivability. So over the past 20 years, there's been a multitude of studies on this. And I've actually published a number of myself. And if you look at the data from this, we know that the implant survival rate is very high, 98% plus. The prosthetic survival rate, extremely high, close to 100% in most studies. And we know that if an implant is going to fail with this procedure, it's typically going to be within the first 6 months of placement, prior to the delivery of the final restoration. So once we put the teeth onto these implants, the final set of teeth, we know that with proper maintenance, hygiene, that the patients are going to be able to expect a good long-term outcome. And, a lot of people, a lot of dentists and practitioners really look down on this procedure. And to be honest, in my experience over the years, it's because they've never done this procedure. They've never had any association with it. They haven't experienced it personally. And once they do, they see that this is really a life-changing procedure for a lot of patients, and they see the value and benefit and how it really impacts patients' lives. And we know that we can do this procedure and that the data supports it, and that we have 2 decades of literature that back up the treatment that we're doing on this type of work. So why does this procedure work? If we're putting a single implant in, we're having to wait 3 months, and in the past we used to wait 6 months and bury them and unload them. Why can we put these implants in and we can angle them and we can attach something to them immediately and they work? Where in the past, that was just unheard of. Well, the keys to this, one of the keys is cross-arch stability, where we have the implants in the back supporting the implants in the front. We have the implants on the left supporting the implants on the right. We have diagonal stability. We tie all this together with a screw retained, arch. So we have an arch screwed together with implants that are forming triangles. So we have something that's very, very stable. And if we look at cross-arch stability, there's a number of articles. And Berkvis in 2008 had a very landmark article. And in this, and I probably refer to this article daily when I'm doing consultations, and I do all my own consultations. I don't have a business person that sits and do the consultation with the patients. I do the consultations personally with the patients. And when we have implants and we splint them together, that we are able to achieve stress reduction by a factor of 9 compared to unsplinted dental implants. That's a significant number. 9 times reduction in stress when we splint the implants. Pieri in 2009 shows that improved stress distribution is resulting in higher implant survival. Kim showing that splinted tilted implants showed lower stresses than splinted axial placed implants. Jensen in 2014 show that we have higher implant survival in cases with low initial torque values if we achieve cross-arch stability. And they show some cases where they're having, very low initial torque value when they're placing implants, but if they're splinting, if they're achieving cross-arch stability, that they're able to allow these implants to survive with immediate function. And Balshi also showing the same thing, that when we have cross-arch stability, we have improved load distribution, it's limiting micromotion, and that it's avoiding overload concentration on individual implants, because we're basically spreading the wealth, or spreading the work. So one implant isn't doing all of the load. And this also requires something else that I find a lot of dentists overlook: occlusal adjustment. If you are doing full arch cases, you really, really need to know your occlusion. Backwards, forwards. Occlusion is something that's very, very important, because that can ruin a lot of your cases. And it all comes back to this: load distribution, stress distribution. We want to avoid concentrations of heavy loads in any one particular area. So we know this is one of the reasons why this particular type of technique works. The strength of this is in the design. And this slide for me has probably sold tons of cases. So if you want to use this in your practice, put something like this in there. But if we have a all-on four style case, an immediate load type function case, and we now bind everything together. So we take all our implants, and we're showing basically how the stress distribution occurs. If you look at this, it's very similar to traditional bridge building. Bridges that we've been using for thousands of years. This bridge on the right, you can drive a locomotive with millions of pounds on it, and the bridge is going to support it. And when you look at the two, you can see how they're very similar to one another. It's a truss design. And if you go to any basic website, and this is funny because I pulled up this website, and look what ad pops up on here: place 30 implants in 5 days. Does a computer see what you're doing? Yeah, obviously it does, because there it is right there. Just when I look up, what a truss is. If you look up what a truss is, the design of a truss, which is usually a variant of a triangle, creates a very rigid structure and one that transfers load from a single point to a considerably wider area. So think about that. We are putting in our implants at an angle to avoid the sinus. We're putting it in at an angle to avoid the mental foramen, the anterior loop of the inferior alveolar nerve. And when we have straight implants combined with those angle implants, we're essentially creating a triangle, and we are creating a truss. And then we're attaching an arch to that truss. So arches, extremely strong. Think about Roman aqueducts. These things have been around for thousands of years. They're still standing. And now we have a triangular truss formed by our implants, and we combine these two together and have them as one singular unit. We have something that's extremely strong, and that's one of the reasons why this procedure works. So, we think about what we were taught in school. Implants had to be straight and parallel, and if they weren't parallel, you didn't do your implant right. Well, let's look at angled implant stress patterns. Kim in 2011 did stress analysis of angled implants, applied 13 kilogram loads to the implants at 3 different sites, first, second, premolars and first molars, because these are typically the cantilever sites. And if you listen to my pterygoid lecture previously, you know some issues with cantilevers. And so this is a good study because it's applying a heavy load in cantilevers, which was where we're doing a lot of our mastication loads. And what they found is that when we had angled implants compared to an axially placed implant, we had about a 17% stress reduction. And that's because of our truss variant design. If we look at stress patterns from Ozan in 2018, finite element analysis, utilizing multiple different inclination models, 100 Newton load on screw retained restorations. And what they found was that the lowest stress value patterns were seen when we tilted the posterior implants. If we look at bone loss patterns with tilted implants, because that was another question, is if we're angling these implants, we have these cantilevers, are we going to have more bone loss with these implants? Well, in 2012, Ada Ali did a study, meta-analysis, and in this study, they had pretty strict inclusion criteria. And what they found was that marginal bone loss patterns between tilted and axial placed implants were similar. And so we know over the years, there's been a number of studies looking at bone loss patterns on straight implants. And if we're now comparing them to angled implants with all of these studies and these retrospective studies, meta-analysis studies, we can now see that the bone loss patterns are similar. And with the caveat of that, I would say that is if your prosthesis is designed properly, if your occlusion is adjusted properly. And that would really be for both styles of implant, because if you have a straight implant and you have bad occlusion, you're going to have problems. If you have an angled implant and you have bad occlusions, you're going to have problems as well. But we know that if both are designed properly, the bone loss patterns will be similar. And there's a number of studies that have now compared tilted bone loss patterns versus axial or straight bone loss patterns. And we know that they're very, very comparable. So we can really put that to bed. We know that there's not really a difference between bone loss patterns in the two styles of implants. So when we are doing a dia arch or an all-on-4 style procedure or any other name that you want to give it, what we're talking about is same day, full arch, implant rehabilitation. Okay, and when we're doing this, you really have to change the way that you're thinking, because when we're in dental school, we're taught one style of thinking, and we're taught to save as many teeth as possible, no matter what the cost, no matter what the consequence. And once you start doing these types of cases, these full arch same day type of cases, you need to change the way that you think. You need to change the way that you're viewing some of these cases, because you're looking at the greater good of the mouth in the long term. And you're taking also into consideration the needs of the patients, the desires of the patients. And this can really change your treatment planning for a lot of these cases. So if we have a case like this, we know there are multiple options. We have conventional dentures that we can utilize. We have snap-on dentures that we can utilize. We've got conventional implants that we can utilize. And we also have an immediate load type procedure, an all-on-4 dia arch type procedure that we can utilize. So we have a lot of different options. So I'm going to show you a case, and this is an old case of mine. And this shows you where, when you're viewing some of these cases, the way that you can possibly change your thinking, because I still get patients every single day. I did consults today, one in particular that was very similar to this, where a dentist will treatment plan with a very traditional model. And many patients are not seeking that anymore. They know that there's options such as this available where they can get a new set of teeth that they can function with in one day, as opposed to having to wait for a significant amount of time, undergoing many surgeries. And so this case, really highlights this. So if we look at this particular case here, we've got pneumatized sinuses because the patient's been missing his posterior maxillary teeth for a while. We have a deficient anterior maxillary ridge, again, because he's been missing teeth for a while. He's wearing a maxillary partial denture. He's also got some ridge deficiencies in the mandible because he's been missing teeth for a while. He also has some teeth that are angled and not quite in the right position. So he has a number of problems. And so in this particular case, to treat the anterior deficiency, I did maxillary block grafts. So 2 block grafts in the anterior maxilla, let those heal, come back, and I place 4 implants. Well, we don't have any bone in the posterior sinuses, so we got to do 2 sinus lifts. So we did sinus lift on the left, sinus lift on the right, open sinus lifts. And now we can come back and place implants. In the mandible, we had deficient mandibular ridges. And so to treat that, I did bilateral ridge splits. And so many years ago, I wrote an article in Journal of Periodontology on piezoelectric hinge ridge splitting for the mandible. And so this is how we do it. I'll take the piezoelectric handpiece, cut the ridge, green stick fracture, use a ridge splitting osteotome, I'll fracture the ridge, let it heal, we come back and we place implants. So we do this on both sides. And then we place a whole bunch of implants. And you can look, we've retained a couple of the natural teeth that were still quote unquote healthy. And we placed a whole bunch of implants. So we see this patient before treatment. This is after all the bone grafting is done. So we look at what did we do? We did sinus lift, sinus lift. We did block grafts, ridge split here, ridge split here. That's a lot of different surgeries, a lot of pain for the patient, a lot of cost for the patient. We then place a whole bunch of implants. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 implants that we have here. And then we do our restorations. So total cost of treatment, we had extractions of bone graft, we had block grafts, sinus lifts, ridge splits, dental implants, implant restorations, sedations during all these surgeries. So total cost for this was at least $74,000, $75,000 for the patient. And, I could tell you this case was done back when I was in the military. And so fortunately it was at no cost to the patient, but I ended up paying for the case. You ended up paying for the case because it's a taxpayer funded case. And this patient, received some great treatment, but if this was done in a private practice setting, it's going to be fairly expensive, maybe even more expensive than this. And the time is going to be fairly significant. So let's look at the time cost of the patient. We had 4 surgical appointments. We had multiple surgical follow-up visits. So if this is a person that's working out in the civilian world, every one of these surgeries, they have to take off work afterwards to recover from the surgery. Then they have follow-up appointments. They have to take off work for that. Then they have pre-prosthetic appointments. Then they have prosthetic appointments. So the total treatment time is 18 total months, sometimes even longer, and a lot of visits that they're having to come in for. And then even after all of this work is done, because we still have a few natural teeth remaining, it's possible those natural teeth could be crowns. They could need endodontic treatment. They could possibly need to be extracted. And if they're going to be extracted, they're going to need bone grafts, additional implants. And so even though the patient had already spent this significant amount of money, there's still a potential that they can spend even more money, and they're going to have to undergo even more surgeries. And so this is where, if you're looking at a more traditional style of treatment compared to a full arch style of treatment, it changes the way that you look at some of these cases. Because that last case where we did all of that treatment over 18 months of time, I could do this now definitely in one day. I could take those remaining teeth out. I could do a couple of zygomatic implants, a couple of pterygoid implants in the mandible, a vomer implant. I could get them treated in one day. I don't have to do any bone grafting. I don't have to have him miss all that work that he missed. It can be, no denture, no partials. So significant difference in the two types of treatment. And Babish actually published an article looking at this in 2014, where they had two patient populations. They had conventional implant patients and they had all-in-4 style implant patients. And what they found was that these full arch patients on average saved at least $14,000, and that they had 12 months shorter treatment times. They had fewer surgeries, fewer follow-up visits. They reported less discomfort, and they reported overall higher satisfaction with their treatment. And this didn't even consider any future possibilities of treatment. So for example, retaining any of those teeth, if any of those teeth go bad, if any of those teeth need root canals in the future, any of those teeth need endodontic treatment in the future, you have to really consider all of those possibilities when you're retaining some of these natural teeth. So let's look at the full arch treatment concept. It's going to change the way that you see cases, and let's look at the surgical procedure. So we're going to go through all the different steps, and really this, in doing this procedure literally every day for the past nearly decade, if you just break this down into steps, it makes it much easier to do, because you're just doing step 1, step 2, step 3, and the process goes pretty quick and pretty easy. So first, of course, after we're doing our anesthesia and getting the patient comfortable, basically what we're doing is a full thickness flap. When I say full thickness flap, I mean get under the periosteum. I can tell you, I watch a lot of doctors do procedures. I get asked to, mentor a lot of doctors on some of these procedures. And one thing that I see a lot of problem in right off the bat with cases is sometimes clinicians have trouble reflecting the flap, and they won't make a very clean incision, and they're in such a rush to reflect the flap that they end up essentially doing a split thickness flap because they're not getting under the periosteum, and they end up just shredding everything, and there's bleeding all over the place. The patient has significantly more pain. They're going to have a lot more inflammation during the healing process. And literally, as the flap gets reflected, because there's periosteum left attached all over the place, I call it, it looks like mushu pork. It's just shredded all over the place. And so get under that periosteum and your flap will just reflect very easy. So full thickness flap, good incision, make sure you get under the periosteum, less bleeding, less post-op inflammation. You'll have less pain for your patient also. They're going to be a lot happier. And these are consistently, if you have an edentulous patient, reflecting the flap is going to be a bit more difficult. It just always is. It's just a more tenacious periosteal attachment. And when you do your incision, one nice little trick you can do is you do your incision with a 15 or a 15C blade, and then flip it around backwards. And then you're using the non-cutting side and just retrace your incision. And when you do that way, it's going to cut any non-incised periosteum. Is also going to not cut any additional incision lines with your flap. So that's sometimes I'll see people and they'll retrace their incision, 2 or 3 times with the cutting end of the scalpel, and they end up with 2 or 3 different incision lines, and it creates a mess. So if you do your initial incision line, turn your scalpel around, retrace it with the back of the blade, it makes a nice clean incision. It'll make your life a lot easier. Next, we're going to extract teeth. A lot of different ways to do that. We'll discuss a few. Then we're going to do bone reduction. And the bone reduction is one of the biggest problems that I see with practitioners. A lot of practitioners are afraid to remove bone. And look, if you're going to do full arch procedures, you're going to have to remove bone, and you're just going to have to not be afraid to do it. If you're already, deciding that you're going to do this bigger type of case, then you're also going to need to decide that I need to reduce bone, because in order to have restorations that are going to be restored properly, and are not going to fracture and not going to have problems, you need to reduce bone. In the maxilla, we're typically looking for 12 to 15 millimeters, and I'll show you how to measure for that. And in the mandible, 20 to 25 millimeters. And I'm talking about utilizing a Masad lip ruler with the bone reduction. So I'll show what I'm talking about with these particular measurements. After our bone is reduced, now we're going to do our implant placement. And then afterwards, we're going to do bone graft placement. Now, some people don't bone graft after these procedures. Sometimes they call it a no bone solution. And, I'll show you why I personally like to bone graft. One of the reasons for that is you never know if you're going to have to come back. You may have an implant that fails. If an implant fails, you will want to have grafted that defect when you had the chance, because you may need to utilize that site again. So I can tell you that any defects, any residual extraction sockets, I'm grafting at the time of surgery. Then we need to do tissue reduction. And this is a step like bone reduction, where I see a lot of practitioners skimp on this step, where they don't even do it at all. This can really make your life a lot easier if you're restoring the cases. And if you're working on a referral basis to where you are a surgeon working with a restoring dentist, this is going to make them much happier, because when you trim the tissue, it makes a world of difference on the prosthetic end. It makes it easier to do the pickup of the transitional prosthesis. It makes it a lot easier to take your impressions. It makes the final restoration fit a lot better. And it just takes a few extra minutes. So your surgery may take a little bit longer, but it's going to make a world of difference. And I say a lot of people just skip this step entirely. Then we need closure. And I'm going to show you a suture technique that I've come up with over the years that works extremely well. It's very effective. You never get any open flaps. And once you learn the technique, I think your patients will like it, and I think you'll like it as well. Let's talk about step number one, flap elevation. So we're doing a full thickness flap. So you can see in this case, we're under the periosteum. Very easy to do a full thickness flap. And when we are doing this incision design, one thing that I'll do is I'll just come straight across and eliminate the papillas, and as being a periodontist, just saying that, can get you literally excommunicated from the Church of Periodontics because you're getting rid of papillas. But when you're suturing this, you don't need the papillas anymore. And so as long as there's enough keratinized tissue, then we are just going to cut across at the CEJs and eliminate those papillas. And if you look here, you can see after I've reflected the flap where I still have these papillas remaining, and I'm literally going to just eliminate those. But when I go back to suture my flap, it's going to make a much cleaner closure, and that's because we have a nice straight line incision as opposed to a jagged type incision because we retain papillas. All right, next we're going to do teeth extraction. And when we do teeth extraction, there's a lot of different ways to do this. And what I will typically do is I will go in between the teeth with a burr. I will eliminate a little bit of bone. I will section all of the molars I don't like to chase any fractured root tips. So anything I could do to eliminate root tips, I'm going to try to do ahead of time. But there's a variety of different ways to do this. Some people will use a sagittal saw, and then we'll literally just cut through the bone and take all the teeth out with the bone. And then they'll go back and get the little root tips afterwards. So whichever way works best for you is fine. Just you want to get the teeth out in one piece. You want to preserve as much bone as possible. Some people I see get in a very big rush, and in the attempt to take all these teeth out, they start fracturing buccal plates left and right. Well, you're going to want those buccal plates later. So you want to keep all that bone. So if you need to take a few extra minutes to section a tooth, then section the tooth. because the key here is you need to keep as much bone as possible. So once you have these teeth out, now we're going to do bone reduction. And you can see in certain cases, we're going to need to take a pretty significant amount of bone away. And so on this particular case, you can see on the right side, I've got about nearly 9 millimeters of vertical bone reduction. And now we're going to go back and do this on the left side. So how do you determine how much bone to reduce? I get that question quite a bit. And a simple way, a very simple way to do this is you get a Mossad lip ruler. And these lip rulers are used very commonly for denture fabrication, and they're available. You can get them on Amazon, and they cost, I think, like $10 on Amazon. And a Mossad lip ruler, how do we utilize this? Well, on the back side of the Mossad lip ruler is a little notch. And so after we do our full thickness flap reflection and we take the teeth out, we take this little notch, which is right here on the back side, and you will place that directly onto the bone. And once you place that onto the bone, then you let the lip rest. And that is the measurement that you're looking at. When the lip is resting and the ruler sitting on the bone, in the maxilla, if we're doing a hybrid type restoration with, say, a titanium bar and acrylic, or we're looking for about 15 millimeters from bone to lip. If we are doing a zirconia, then we can have a little bit less, say 12 millimeters. In the mandible, we're utilizing the other end of this. So we're utilizing the little lip down here, and we're placing that on the bone, and then we're measuring to where the lip position is. So in the mandible, we're looking for about, on average, 20 to 25 millimeters on the mandible. That doesn't mean your restoration is going to be that thick. That's just after the bone reduction and the lip is resting. That's what we're looking for with the Mossad. Okay, so you can see on a case here, on the left side, I am placing the Mossad lip ruler with the notch directly onto the bone after we've taken the teeth out. I'm letting the lip rest, and you can see we've got, looks like somewhere around 8 millimeters. And then after I do all the bone reduction, then I place the Mossad lip ruler onto the bone after the reduction. And now you can see I've got about 14 millimeters or so. So I've got plenty of room now to make a restoration where I can hide the prosthetic transition line, that I have adequate thickness, that I'm not going to have to worry about this restoration breaking. Now, when you're doing bone reduction, of course, you need to be cognizant of how much bone you have. So if doing that amount of bone reduction is going to eliminate all the bone that you have, then you don't necessarily want to do that. So you have to keep, all factors in mind to where you're satisfying the prosthetic end and the surgical end. And this is where, your pre-surgical analysis, looking at the smile line, looking at the bone availability, is coming into play in doing these procedures. All too often I see practitioners, they, have a patient come in and they just are straight looking at the x-ray, and they're really not considering some of these other factors, such as the lip mobility, the smile height. And those are some of the things that you need to look at, because when you do your prosthesis, you need to hide that transition line. You need to have an adequate thickness of material in your restoration. And in order to do that, you're going to have to do bone reduction. And this is a simple way to determine how much bone reduction to do. Bone reduction, you can do this a variety of ways. We use an OsteoMed, just high-powered handpiece in the clinic. Some people, utilize Hall's handpieces. Some people utilize piezoelectric handpieces, which, I think take way too long. But however you're going to use it, just make sure you're doing an adequate amount of bone reduction. Okay, so you can see after we do our bone reduction in this case, everything's nice and flat, nice and even. Then make sure you're also rounding any sharp edges, because when you go to suture the flap, we don't want any sharp edges that could possibly perforate our flap. What we're doing in the mandible and the maxilla is we're creating what's called a bone shelf. And so Jensen published a number of articles about 10 years ago, the maxillary bone shelf and the mandibular bone shelf. And this is a nice little picture here because we look at a mandible and we can see that originally what we had was a knife ridge mandible. However, once we reduce this, you can see that we now have a nice thick area, a nice shelf to place our implants. Whereas if we hadn't done this bone reduction, this area up here, it's much too thin. We're going to have a lot of thread exposure of our implants. But when we get down to here, we have a ton of bone to place our implants. And so we want to create this shelf. In order to do that, you can see we had to do quite a bit of bone reduction, but it ends up accomplishing our goal in creating a space where we can place implants, not have any exposed threads, and have adequate prosthetic restorative space. So again, in the maxilla, we're doing the same thing, the maxillary bone shelf. So purpose of bone reduction, why are we doing it? And I've hit it a few times, we're trying to create prosthetic space. Remember, when we're doing these surgery procedures, they need to really be prosthetically driven because no one ever comes to see you saying, I want implants. They want teeth. They want teeth to chew with, they want teeth to smile with. And it's great that you can place implants, but if they're not placed in the right spot and you can't do your prosthetics, then your implants are pretty much worthless, even if they're integrated in bone. We need to have the prosthetics in mind at the end of the day. So we want to have proper thickness for a strong restoration that's not going to fracture. We want to eliminate the prosthetic transition line. We don't want anyone seeing the edges of our restoration. We want to eliminate any canting. We want to eliminate any tilting of our occlusal plane. We want to also eliminate any infected bone, and bone reduction will do this. And we know that as we move apically, typically the bone in most cases gets thicker, and that's going to be good for our implant placement because we're going to have more bone circumferentially around the implants. Now, one little trick that works very nicely is you can take a Fox plane, and if you remember a Fox plane from dental school, if you're making dentures in your clinic, take a Fox plane, sterilize that, and then we'll place that directly onto the bone after bone reduction. And now we can utilize that Fox plane to parallel the interpupillary lines, Frankfurt horizontal plane, and it is very handy. And I've done, thousands of these cases, and I still use a Fox plane, for every single maxillary case. And that tells me if I need to adjust one side more than the other. It tells me if my posterior maxilla has dropped more than the anterior, my bone reduction, and as a very good, quick visual check. Okay, so after we have all our bone reduction done, now we're going to place our implants. And when we're placing our implants, in the mandible, certain things that we want to keep an eye out for are going to be the mental foramen. And you want to reflect your flap adequately to where you can see the mental foramen. Now, a lot of times I'll see practitioners do this procedure and they're not adequately reflecting the flap, and they can't see where the mental foramen is. If you're going to do this procedure, you need to be able to see this. And also, if you notice on this flap reflection, you can see it's very clean. There's no mushu pork anywhere. I don't see shredded periosteum all over the place, because when you get under the periosteum, it'll reflect very quick and simple, and you'll have a nice clean area to work with. And also, it's going to really minimize the amount of bleeding that you're going to have. So when you're placing these implants in the mandible especially, definitely 100% you got to find the mental foramen. Okay, now our implant insertion. And this is actually a picture from one of the implants that we placed today. And now we are placing our implant into our osteotomy. And when we're placing this, we want to achieve really as high an insertion torque as we can get. And I'll explain to you why. Is lower torque a problem? If you look at nearly every all-in-4 style study, when they look at implant failures, they almost always have one thing in common. And that one common thing is low initial insertion torque value. So what is the minimal amount of torque required? And we look at a number of different studies. There's tons of study in the lit. And, some of them I published myself. Typically, for insertion torque, you're seeing anything from 32 to 35 Newton centimeters of torque. Somewhere in the low to mid 30s is ideally what we're looking for. Now, there are some studies that have looked at low torque. Is low torque a problem? Well, the GD in 2012 found that if you have at least 2 implants that have greater than 25 Newton centimeters of torque, they will help to stabilize other implants that have less than 20 Newton centimeters of torque. And then you still get very high implant survival rates, over 98%. So basically you have a team, and the stronger implants are supporting the weaker implants. So during this initial osseointegration phase, during that first 8-week healing period where you have bone dying back and then bone healing and forming and osseointegration happening with the implants, these stronger insertion torque implants are going to support the weaker insertion torque implants. Now, Jensen in 2014 published a study where they had implants with torque values of as little as 15 Newton centimeters, and they were achieving up to 100% implant survival as long as they had what we mentioned earlier in the lecture, cross arch stability and splinting. Because when we're taking this arch restoration and we're screw retaining them to multiple implants, we're spreading the work, we're spreading the load. So now you don't have forces concentrated in one area. They're concentrated throughout the entire arch. And that is one of the reasons that we can immediately load these cases as opposed to other, say, single implant style cases where we may not necessarily be able to immediately load these. And so, these studies show that, if we have less insertion torque, it can work. Now, after doing many thousands of these cases over, a decade period of time, and with my personal opinion on low torque, not good. I hate low torque. That's usually a bad day in the clinic, especially in the past before I was doing zygomatics and pterygoids and some of these other styles of implants. If I had a low torque day, if I had soft bone, it was a bad day because that meant it was going to be difficult to load our case. So in my clinic, if we had torque that was less than 32 Newton centimeters, what could we do? And some of these things are used to, what I used to do in the past, and I can tell you what I do now, but we could attempt to place a wider implant. So say you place a 4.2 millimeter implant, you're not getting quite the insertion torque that you want, then you could place a 5 millimeter implant. As a matter of fact, I did that just today, just a few hours ago. And I'll show you that at the end of the lecture when I put up the pictures of the cases we did today. We can attempt to place a longer implant. And of course, you need to be cognizant of the anatomy to do that. If you're in the mandible, you need to be aware of where your inferior alveolar nerve is. If you're in the maxilla, you need to be cognizant of where your sinuses are, where your nasal cavity is. So if you're placing a longer implant, can you place a longer implant? Are you going to impinge on any of those anatomic structures? But that's another option that you have. You can seek an alternative location for your implant. Now, many times when we're doing these procedures, alternative locations are a luxury that we don't have because many cases, we don't have significant amounts of bone. And if you have a patient that just has acres and acres of bone and one spot doesn't work, then you have the luxury of choosing another spot. But many times we don't have that luxury. And one thing that you can do, and for me, it was out of necessity, just because we see a lot of different types of cases, is you could start doing other, what I call exotic styles of implants, pterygoid implants, zygomas, vollmers, piriform rim implants, inferior border of the mandible implants, because you're looking for these areas where there's dense, hard basilar bone to help give you higher amounts of insertion torque. Another option that you have, and again, this is if you have the luxury of enough bone to do it, is you can place additional implants. And I can tell you in the past, that was my go-to. Before I was doing some of these other styles of implants, I would place a wider implant. I would try to place a longer implant. I would try to place additional implants because I was trying to get more implants that I could spread the load. I can distribute the stress of the restoration to all these additional implants. So we see a case here where I've got 1, 2, 3, 4, 5, 6 implants in here because either the bone was soft or it was a big patient, big strong guy patient, and I needed a little bit more support for our restoration. This is an interesting case because in this case, I needed a longer implant. I utilized a Norris Medical TerryFit implant, 22 millimeters, to engage the inferior border of the mandible because this patient just had extremely soft, hollow bone in this area, and I could get absolutely zero torque. And as you can see, I had a relatively small implant posteriorly, and I really wanted some torque in this area. And the only way that I could achieve it was by going to the inferior border of the mandible. Well, the only way I could reach the inferior border of the mandible is I needed to utilize a longer implant. And that meant I had to get a 22 millimeter, basically pterygoid style implant that could engage that dense bone at the inferior border. And so this case actually worked very, very well, no problems, and it was a good solution. We can utilize other areas. So in this particular case, utilize the pterygoid because we had dense bone in the pterygomaxillary complex, the pyramidal process of the palatine bone, the pterygoid process of the sphenoid bone, dense, hard type 1 bone that is in the, a sea of the very soft type 4 bone that is typically found in the posterior maxilla. We've got zygomatic implants, extremely strong bone in the zygoma. And if you see a case like this, somebody that was previously edentulous, they have very minimal bone. When we utilize zygomatic implants, pterygoid implants, we're able to engage very dense, hard bone that's going to give us a lot of posterior support where we're doing a lot of our mastication back in the molar area. And then in the anterior, in this case, we utilized engaging the vomer, another area of dense, hard bone in the anterior maxilla that if we need it in a pinch, we can engage the vomer, and that helps quite a bit because many times the anterior maxilla will be extremely soft. And so these are some alternative locations that when we're doing standard all on X style procedures that we can utilize to engage. Now, once we have our implants placed and we have adequate insertion torque everywhere, now we need to do a little bit of housekeeping. We need to look at the platform and we need to make sure that we have unimpeded access so we can seat our abutments. Because if you have any bone in the way, when you're going to seat these abutments, you're not going to get complete seating. And what happens is you may feel like your torque is adequate when you're seating the abutment, but the implant platform is not completely engaging the abutment. And then what will happen is you may have some of this bone necrose as healing occurs. Anytime you reflect a flap, you get a little bit of bone loss. Anytime you do a little bit of bone reduction, you're going to get a little bit of additional bone loss afterwards. And now, if your platform wasn't fully seated on your abutment, now you have a loose abutment. And loose abutment can cause loose screws, can cause fractured screws, can cause fractures of your transitional restorations, ultimately can even cause failure of your implant. And so what you want to do is take a high-speed, reverse air handpiece. We use a simple 45-degree reverse air handpiece and ramp the bone. And so we'll take the bone down, clear an area around the platform, and this is going to do a few things. One, it is going to allow your abutment to fully seat. The other thing it's going to do when you ramp this, when I do a ramp, I like to create a long sloping ramp So if you look here, this kind of slopes all the way back to here. And you can even see a couple of my little chatter marks on here when I did the reduction. And, some companies will sell a profile kit where you can screw a little instrument into your implant. And you just, drill down and it creates a little bit of clearance around the implant. Well, that's fine, and that'll allow you to seat your abutment. The problem that you're going to run into later down the road is if you do it that way, the tissue, follows the bone. And, in perio, we had a saying, it was, the tissue is the issue and the bone sets the tone. And, if you don't adequately ramp this bone, if you don't smooth this and you just take a tiny bit away right around here and you leave all this excess bone all in these other areas, you'll be able to seat your abutment. But the problem is after all the tissue heals, that bone is still going to support all that tissue, and you're going to have a lot of excess tissue in the way. It's going to make it difficult to take impressions. It's going to make it difficult to seat your restoration. So if you can ramp the bone and make this much more gradual, it'll make life a lot easier, especially on the restoring dentist. And if you're the restoring dentist, you are going to appreciate it. And if you're restoring dentists or referrals, they're going to also appreciate it, because if every time they get one of your cases, they have a whole bunch of soft tissue they have to deal with, they may not refer anything to you anymore. If the other guy that refers them patients, is doing adjustments, and, it's much easier to take impressions on the cases that come from that person, they may not refer to you anymore. So take a few extra minutes, ramp the bone, clear away the platform. It's going to make life a lot better for you, a lot better for your restoring dentist. So then we're going to do an abutment access check. And if you're still doing conventional dentures and a lot of digital is going on, and we do a lot of digital in our clinic, or if you're still doing traditional implants, dentures with your implants, one thing that works well is you can cut 3 little channels like this. And this is something that we did for many years. And you create 3 little channels like this, because typically that's going to be about your implant positions, somewhere in the incisor area, somewhere in the premolar molar area. And when you seat this, when you put your multi-unit abutment on with the pin, you can see where your exit point is. So this gives you a quick little check to see if you're going to have adequate clearance, and that if you need to change your abutment angulations, because I can tell you that one of the things that is the biggest pain is you have everything finished, you have everything sutured, and now you have, say, a 17-degree abutment in one area, and now you find out that that's going to be coming out a little bit too facial. And now you got to change that 17-degree abutment to a 30-degree abutment. And it's just a lot more difficult to do when you already have everything sutured. So if you can place your prosthetic on here with a couple of access channels, you can seat it, you can see where your abutment's coming out. It just ensures that you're going to have a lot better placement and a lot less changing of abutments after you have everything already sutured. And so you can see in the posterior we're checking, and the anterior we're checking, and we know we're in the right spots. Now we're going to attach healing caps, and then we're going to do tissue reduction. And so you can see in some of these cases, in the top left, you can see there was quite a bit of bone reduction done in this case. You can see that, now my flap, I've got about 13 millimeters of excess tissue in this area. And so afterwards, we're doing a lot of soft tissue trimming. In the top right picture, you can see that's a UNC 15 probe. So this is 15 millimeters. And if you look at the size, and that's 15 millimeters here. So some of these tissue chunks, are pretty substantial. And we're utilizing, sharp 15 C blades, 12 B blades. And that's one thing is, if you're doing these procedures, don't be afraid to utilize a bunch of new blades. Some of these blades, use them a couple of times, they get dull very quickly. And then it's literally like you're trying to cut tissue with a butter knife. It costs an extra $5, use a new blade, trim the tissue. It cuts a lot smoother. It makes your life a lot easier. It also makes the patient have a lot less pain because they get a lot cleaner cut. So trim the tissue. After you trim the tissue, one other thing that you can utilize is a biopsy punch. And the biopsy punch will also help to trim a little bit of tissue away. And it will allow you to get a much cleaner closure. And so, yes, it will take a few extra minutes if you're doing it this way. But again, at the end of the day, it's going to make your life a lot easier. The patient's actually going to heal a lot better because they're going to have a much cleaner closure, a much less redundant tissue. Next, bone graft placement. Again, as I mentioned earlier, if I have any residual sockets, if I have any defects, I'm placing bone. And why am I placing bone? Because if you look at a patient like this, where you have a number of large defects, when we graft these areas, if we had an issue where an implant failed and we needed to come back to, say, either of these areas where we have bone loss, now hopefully with our bone grafting, we're going to have bone in those areas that we could utilize in the future if it ever needed to be done. And so here you can see we have a nice amount of bone formation. If we need to go back there, we could. Now, soft tissue closure. So in doing soft tissue closure, one comment that we typically receive in the office is compliments on our closure. And, just that it's very clean, that it makes it very easy for the restoring dentist. And I can tell you that in doing this, it's a technique that I've developed over the years. And I just use 4-0 chromic gut sutures for almost every single case in the office. Over the years, in the past, I used to have a variety of sutures, which a lot of clinics have. You'll have chromic gut sutures for certain procedures and vicryl sutures for other procedures and PTFE sutures and silk sutures and, nylon sutures. And I can tell you one of my colleagues years ago told me, just to use chromic gut. And I said, no, that's not going to work. It's too weak. It won't work. And he said, no, give it a try. So I did. And I can tell you that for many, many years now, all I've used in the clinic is chromic gut. And it works spectacularly well, especially for this technique. When you're doing full arch, if you want to use a resorbable suture, the benefit of that is when the prosthesis is seated at that first follow-up visit, you don't have to go dig out all those sutures. And when you have a prosthetic that is sitting on top of a bunch of non-resorbable sutures, you have to go get those out. And that's a pain to do. Or you have to take the restoration off and you have to go dig them all out. So if you can utilize a resorbable suture, it makes your life a lot easier. So, how are we doing this? Well, I call this the Texas two-step closure. The reason I call it the two-step closure is basically I'm utilizing 2 sutures for the entire arch. And when I make 2 sutures, I'm basically doing 1 knot in the midline. And I'll start right up here. And then what I'm doing is I'm considering each of these areas as a section. Okay, so I've got a section here, 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 and here. And basically between each section, I'm doing 2 sutures essentially. First, I start off with a horizontal mattress. Okay, when I do the horizontal mattress suture, what that is doing is 1, it everts the tissue. So it is flipping the tissue to where the connective tissue of each portion of the flap is going to connect and kiss the connective tissue of the other portion of the flap. That's going to make things heal much better. If you don't evert the tissue like this, then many times what you'll have is connective tissue of one side of the flap is being covered by epithelium of the other side of the flap, and that's just not going to heal very well. You get flap separation. So if you do a horizontal mattress suture first, then this is all one continuous suture. So you're doing your horizontal mattress first, and then after that, then you go back and do a continuous loop suture. And what that continuous loop suture does is it now tucks down and compresses that everted tissue. And so that first horizontal mattress, in addition to everting the tissue, it is basically taking all of the tension off of the incision line. So now your incision line is tension free. And now you're utilizing that continuous loop suture to close the incision line. There's no tension on it. And after you close this section, then basically you do a horizontal mattress across, and the same thing. You pass underneath, you come out here, horizontal mattress here, come back here, horizontal mattress here, come out here, and then you go back and loop it back. Then you go to the next section, horizontal mattress, loop it back. And when you close it like that, everything is going to be very tight, very clean. And in order to also do that, you also have to trim the tissue beforehand. And so there's a lot of little bits of tissue trimming, and it takes a few extra minutes to suture this way, but it makes it a lot cleaner. It makes it a lot better for your prosthetic portion of the treatment. And so again, when we're doing this, it's 2 total sutures for the entire arch. And if you notice with this suturing technique, you don't see a whole bunch of suture tails everywhere. And that's also beneficial because when you're doing your pickup of your transitional restoration, you don't have all these extra suture tails that can get caught up in your acrylic when you're picking up the transitional cylinders. So you basically have 1 suture tail in the middle and 1 suture tail at the end, and that's it. Everything else is very nice and clean. So in doing these procedures, another thing to consider is how many implants are we going to place in an arch? And this is something that, a lot of dentists can't answer. And I'll have a lot of patients that will come in for consultations and they'll say, well, how many implants do you put in? I said, well, basically I put in as many implants as I need for the procedure. And they said, well, I went to so-and-so's office and they told me that they always put in 6 implants and that 6 is better than 4. I said, well, really? I said, well, why is that? I said, why is 6 better than 4? And they said, well, they just said it was because it's more implants. I said, well, there's plenty of studies out there that show 4 implants are more than adequate. Why do they put in 6? They really can't give you an answer other than 6 is bigger than 4. I was like, okay, well, spectacular. You're a genius. 6 is bigger than 4, but why do you need 6? Well, there's a reason. And we make these decisions during surgery. So we look at these cases, in the top left, we've got 6 implants on the top. We got 6 in the bottom. In the middle, we also have 6 implants, but a little different design. In the bottom, we have 4. Is one of these better than the other? No, it all depends on the case. Each one's individual. So how are we going to decide which case is going to need 4? What's going to need 5? What's going to need 6? How do you make that determination? Well, we have to look at a number of different things. We have to look at the dimension of the smile. And when I say dimension of the smile, I'm talking about how much lip mobility there is. So when somebody smiles, do they just show the incisal edges or do they show all of the incisor and some of the gingiva? Also, how wide is their smile? Are they showing all the way back to the second molars? Some people have very, very big, wide smiles. Some people have very narrow smiles. We also need to consider the anterior-posterior spread, or the AP spread. We need to consider the composite torque value, and we'll discuss what that is. Basically, the insertion torque for all of the implants. If we add that up, what does it add up to? And is it enough to give us a predictable, successful outcome for our restoration? We need to consider the dimensions of the bone that we're putting the implants into. We need to consider the size of the patient and any possible parafunctional habits that the patient may have. So if you look at this patient when she smiles, this is somewhat of a normal smile. Now, I'll always ask the patient to give me a smile, and then I will tell them, okay, go ahead and smile now as big as you can. And so when this patient smiles much bigger, we can see that she shows a lot more teeth. She shows almost all the way back to the second molars. She shows a lot of gingival tissue. And You may say, well, patients don't typically smile like that. Well, I can tell you that a lot of patients do smile like that. And a lot of patients, when they're laughing and interacting with people and not thinking about their smile, sometimes they will smile with a very strong, big, exaggerated smile. And you need to be cognizant of this before your procedure is done, because it can really cause you a lot of problems that you can't fix if you haven't considered it ahead of time. So if we look at a patient like this, and they have a xerostomia, so they have a lot of recurrent decay and a lot of these restorations, and so they're needing full arch treatment referred from their dentist. And so we're going to trace their sinuses. And so we can see that the sinuses extend all the way up to the canines. And so if we're going to place implants in the traditional, say, all on four style full arch immediate load protocol and placing 4 implants, typically our restoration is going to extend about to the first molars if we didn't want an excessively long cantilever. Now, this patient has lived her whole life with a full set of teeth all the way back to the second molars. And she has a very, very wide smile. So when she smiles, you can see all the way back to the second molar. So if we just restore with this, then when she smiles, we're going to see that end of the restoration. We're going to see a little black space in the buccal corridor posterior to the restoration, because this patient shows all the way to the second molars. Now, if we extend the cantilever to try to hide this, well, now we're getting into a situation where our cantilever is too long. And when our cantilever is too long, now we have possibilities of prosthetic fracture, screw fracture, abutment fracture, even implant failure. So we don't want to have that happen. And so in this particular case, way that we can help our all on X style restoration is by adding some additional support. And to do that, for this case, we could use pterygoid implants. So now we have our traditional style treatment all on X, where we can utilize, say, our Norris Medical Tough implants, and then we could utilize the Norris Medical Fit implants posteriorly to give us a little bit of additional support and eliminate cantilever. And so we have this case and ended up treating it like this, where now we have full extension all the way back to the second molars. So when the patient smiles, we aren't seeing any black triangles or any black spaces. The patient has the full extent of her dentition, which she's been used to her entire life. And the patient really doesn't miss a beat from what she had before to what she has now. Another thing to consider in how many implants that we're going to place is the size of the patient. So if we look at the patient on the left, a much smaller patient. We look at the patient on the right, a much bigger patient. So one of these patients is more than likely going to generate a much stronger biting force than the other patient. And in doing so, we're going to want additional support for those teeth and prosthetics, because that strength of bite force is going to be significantly different between these two patients. Another thing to consider is any parafunctional habits that a patient may have, especially bruxism. When a patient is a known bruxer or has other comorbidities such as restless leg syndrome. So that's one thing that has come to bite me in the past, is patients that have restless leg. So that is one thing I would definitely ask all your patients if you're considering a full arch immediate load procedure. Because when patients have restless leg, they tend to brux very hard at nighttime. And when they're bruxing, they're generating very high amounts of force on the dentition, which is being transmitted to your implants. So in a patient that's a known bruxer, I'm going to try to over-engineer that case as much as possible. I'm going to try to place in additional implants in the likelihood that anything might fail. Then I have backups that I can still hopefully keep my prosthesis, even though one of my implants may have been overloaded. Also, by having additional implants, I've increased the total amount of bone to implant contact. I've increased the total amount of composite torque value that I have to spread the load between all the different implants in the restoration. And so in a patient like this, you can see that we had a number of implants. This patient was a very heavy bruxer, and this implant ended up failing. But because that implant had teammates to spread the load, even though this one implant failed, we did not lose the restoration, and the patient can still function. And this has now been many years in function without that one particular implant, and we didn't have any problem. And the patient never really missed a beat other than us taking out the one particular implant that failed. Because we over-engineered the case, we have additional implants to back up in case something did fail. And that was basically because this patient was a known heavy bruxer. So we talked about composite torque value. What is this? So Jensen mentioned this in a 2015 article in Journal of Prosthetic Dentistry. And basically, the number that Jensen refers to is 120 Newton centimeters of composite torque value, or cumulative value of the insertion torque for all of the implants. So basically, if you're placing, say, 4 implants, and your 4 implants have 30 Newton centimeters of torque for each implant, you have 120 Newton centimeters of torque. And so this number is a rough go-by that if you can achieve 120 Newton centimeters of torque with all of your implants, then you have a fairly good chance of survivability for your prosthesis. And so if you're placing implants that have lower amounts of torque, how can you deal with that? And that's what we covered earlier in the lecture, where you can place additional implants. So now you place an additional 1 or 2 implants, have some additional torque that you can add into your CTV, or you can place different sizes of implants that hopefully can increase your torque values for the individual implants that you do have. So here's a case looking at increasing composite torque value. And in this case, we have an 80-plus-year-old gentleman, and he was missing his posterior teeth, wearing a partial denture that he was looking to get rid of. And he had some implants in the anterior, but the implants in the anterior were having quite a bit of facial thread exposure. I can tell you the bone up here was fairly thin, and we could see that the roots on the remaining maxillary teeth were very small. Those teeth were very mobile, and the implants had a lot of thread exposure because of the bone loss around the implants, the thin bone in this area. And we look at the sinuses, we can see they're very pneumatized. And I offered zygomatic implant treatment to this patient, and he declined based on his age. And so what we decided to do as an alternative was sinus lifts on both sides. And so I did bilateral sinus lifts. And the bone in the anterior was very, very thin, and we weren't able to place any implants there. But because of the bilateral sinus lifts, we were able to place implants in the posterior. And you can see that some of the implant sizes were not quite as robust. And we're placing this into regenerated bone, which is a bit on the softer side. And in order to increase some additional torque for these implants, for our composite torque value, I went ahead and added 2 pterygoid implants. And by adding the 2 pterygoid implants, I was able to engage some dense, hard type 1 bone with very high insertion torque. And that was able to add that additional torque to our composite torque value. So in doing these all-on-X style cases, we've covered, the process of how we're going to do them. You run into many situations where you need what I call a rescue implant. And once you learn how to do these and master these, it will really make your life a lot easier. So some of these can be pterygoid implants. And in pterygoid implants, we're trying to gauge the pterygomaxillary complex. And again, another case, in this case, this patient had a very anterior sinus on the right side. So I did a standard all-on-X style case, 4 implants on the top, 4 on the bottom. And because the sinus extended so far anteriorly in this case, I did a transsinus implant. Now, unfortunately, that particular implant failed. And because that implant failed, now I have to do something about it. So my options are, I can either do a sinus lift, and if I do a sinus lift, I have to let all this bone heal. And while all that bone is healing, this patient still has a transitional restoration. Now, if I extend the transitional restoration to where it was, my terminal support is now here. So I've got this very long cantilever, and there's very high chance this is going to fracture here now and possibly cause problems for this implant. So that's one option if I was going to do the sinus lift. Another option I could do as a rescue scenario is I can place a pterygoid implant back here. I know I can engage really dense, hard bone. I could take this implant out. I could graft this site, and then I could take the transitional restoration, extend it back, attach it to the pterygoid. So now I don't have to put the patient in a shortened restoration. The patient can still function. The patient can still smile, and it really doesn't delay the treatment for any significant amount of time. And so that's what we did. So I went ahead and took out the failed implant, placed a pterygoid implant on the right side, extended the restoration to join that pterygoid implant, and then I offered the patient placing one on the left side to balance out the restoration, and he agreed to do that. And again, if we have any issues like this in the clinic, we don't charge the patient for doing any of these additional surgeries. It's just part of the process. And now we can see that we have a full restoration, that now we have no cantilevers in the maxilla, and the patient did not have to undergo additional surgery of a sinus lift, and it was a way to rescue our all-on-X style procedure. And pterygoid implants have a very good survival rate, very similar to traditional standard implants, and we don't need to go into a whole lot of review of that because it's in other lectures that we are putting on with Norris Medical. Other styles of rescue implants for all-on-X procedures can be piriform rim implants. And in piriform rim, we're basically looking at the aperture of the nose, and this bone is a very dense, hard bone, and you can extend your implants to engage that bone with the apical portion of the implant, and that can rescue you in certain situations where you need to have increased amounts of torque for your all-on-X style procedures. The vomer. So the vomer is another area of bone that we can get dense, hard insertion torque with. And this bone is essentially up in the base of the nose. And we can angle these implants and engage this when we're in a pinch and we need some anterior anchorage. And so you can see in this case, we've anchored into the vomer, and then we are also utilizing zygomas, pterygoids, so we can get support in the maxilla from these harder, stronger type 1 bone sources. So another good spot that you can turn to is the vomer. So Jensen in 2015 published a study where they were looking at piriform rim implants and vomer implants. They had a number of patients, 44, 180 implants just about. Again, very severely atrophic maxillas. And they had very good insertion torque, close to 45 Newton centimeters of torque because they're engaging type 1 basilar bone. Their survival rate was very high, close to 97%. Another rescue implant you can utilize is a zygomatic implant. And so in this case, this patient, we did not have great insertion torque, so we placed additional implants. And unfortunately, some of these implants ended up failing, 2 here. And so the way we treated that was by removing the 2 failed implants, placing a zygomatic implant on the right side. And because we only had a very small implant that was engaging septal bone in the left maxillary sinus, we went ahead and engaged the zygoma on the left side as well. In some of these cases, in hindsight, it would be better to plan these with a zygoma right away, or plan these with a pterygoid and a zygoma right away. But if you get into a situation where you have implant failures, then at least you have options to salvage the case. So some common problems with these all-on-X style cases. One is pre-existing implants. That's pretty easy to solve. There's a number of implant retrieval tools that are made, and you can very easily remove these implants in most cases without too much difficulty. Inadequate bone reduction. And so when people are doing inadequate bone reduction, it can result in very unsightly restorations that have significant fracturing. And believe it or not, this patient is in a final restoration. That is not a temporary restoration. That is a final restoration that was made. And you can see that there was very inadequate bone reduction. We've got a ridge lap here because the bone was not reduced adequately. And when this patient smiles, we could see some of the transition line in these areas. And so just not a very aesthetic restoration. And a lot of that started from the inadequate bone reduction. And so when I see a restoration like this, the first thing that goes through my mind is inadequate bone reduction, because I can see where these platforms are. These platforms are not even to the CEJ of these teeth in the restoration. So there's no way that this had adequate bone reduction when this case was done, just by looking at the restoration that was made. Another case, you can see this restoration. We know that there was inadequate bone reduction performed because you could see there's flanges. There's just not very much thickness of this restoration. And we can see when this patient smiles, we see too much teeth. And when we see too much teeth, that typically either means that there was inadequate bone reduction or the prosthetic is too thick. Another patient, we can see inadequate bone reduction. Another common problems that you typically get with these style procedures, you can have fractured screws, you can have double screws, and a fractured screw, there's a number of different screw removal kits. You can also use a Cavitron, and Cavitron works very nicely to help remove these screws. You just run it in a counterclockwise fashion, running the Cavitron, and many times it'll loosen those screws up. You can have fractured abutments. And I can tell you that over the years, certain implant companies, their abutments had higher fracture problems than other implant companies. And once you deal with enough of those, you don't work with those companies anymore, because that causes a lot of problems. And that's one thing that I've been very happy with on the Norris Medical is the quality and construction of their products. You can have, again, fractured abutments, fractured screws. And some of these stem from poor occlusal adjustments. And so, when you have this type of procedure done, you want to have the occlusion adjusted to spread the force very evenly. And when the occlusion is not adjusted properly, it can result in a lot of problems. And so really, really focus on your occlusion. And this lecture, believe it or not, is actually taken down from an 8-hour lecture. And so we, sometimes we'll spend almost an entire hour discussing occlusion. So it's much more to cover than we can do in a lecture like this. But, being very cognizant of your occlusion can eliminate a lot of these other problems, such as fractured abutments and fractured screws. Other common problems, you can have bad abutment placement, which many times stems from inadequate implant placement. And we can see here we have a lot of facial access holes, which we want to try to avoid during this type of procedure. And that could be from bad implant angulation. And you can see some of these angulations that these implants are just going to end up failing and have problems. And so when you're doing this system, or when you're doing this procedure, there's a number of different implant systems out there. So which one do you choose? The Norris Tough system, these implants are really specifically designed for an immediate load type function. So if you look at the implants, we can see that apically, they have a very specific design. They have very sharp end cutting threads, V-shaped threads in the apical portion. because that's where we're wanting to engage the hard, dense type 1 bone, or to get our higher insertion torque. And then if you look more coronally, we could see that we have compression threads. And so these compression threads are going to, again, help give us some increased stability in some of these areas where you may have softer bone. And then at the very crest of the implant, we have micro threads. They're going to help prevent crestal bone loss. And so this design is a very specific design for immediate load procedures, all on X style procedures, because we're looking to gain very high amounts of insertion torque. And this implant is doing that really specifically because it's designed that way. And if we look at the sizes of this, there's a variety of sizes where we have sizes for minimal amounts of bone in the 3.3 all the way up to 6.0. And I can tell you in today's case, I utilized a variety of different sizes. And if there wasn't all of this options for me to choose from, I would have been in trouble with today's case in particular. And you can see that the sizes in terms of length for these implants are pretty robust. Where in the 4.2, for example, you go from 6 millimeters all the way up to 25 millimeters. And in many implant systems, they just don't have that variety of size. This gives you a lot of options, because when you're doing these procedures, many times you don't know exactly what you're going to run into. Sometimes you need a longer implant than you anticipated. And by having these implants in stock of all these variety of sizes, it can bail you out of a lot of different situations. And having a larger diameter, the 6.0, there's many companies that do not have a 6.0 diameter implant, or they don't have a 6 millimeter implant in terms of height. And those can really bail you out of many, many situations. So having this wide variety of implant stock to choose from, it really allows you to treat virtually any situation. Then we look at the Terry Fit implants. These again are designed for specifically immediate loading, because we have, very similar to the Tough implants, a very aggressive end cutting tip with V-shaped threads that's going to cut through dense cortical bone, giving us very high amounts of insertion torque. And then coronally, we have, again, compression threads. So when we're in softer bone towards the crest, we can compress that bone. And then in the pterygoid region specifically, because many times we'll have thick tuberosity tissue, we have a smooth polished collar, and that's going to reduce the adherence of periopathogens to this implant surface, because we have a nice smooth polished collar. And again, a specific pterygoid style implant design. Now, some of the Tough implants you can use for placement in the pterygoid area. And matter of fact, I'll show that in just a few minutes. So in this, our pterygoid implants come in a variety of sizes, 18 to 25 millimeters, and in a 4.2 millimeter diameter. And then finally, we have our zygomatic implants to choose from. The zygomatics, we have a range of 30 to 60 millimeters in length. Now, this is a very specific design. So with this design, we have 12.5 millimeters of apical end cutting resorblast media treated implant to engage the dense bone of the zygoma. And then the remainder of the implant is a smooth, polished surface, because this portion of the implant is not engaging bone. This is the portion that is extending down from the zygoma down to the arch, where we're going to engage our restoration. And we want a smooth collar or smooth body like this, because it's going to reduce, again, the adherence of pathogens from the oral cavity to this portion of the implant, because this is really specifically designed or for an extra sinus or approach in placing zygomatic implants. The other nice thing with this style of implant is we have a flat platform, where some implant companies have a platform designed at a 45-degree angle. And the problem that I see with a 45-degree angle on your zygomatic implant is that it really paints you into a corner that you have to insert the implant where this 45-degree angle is pointing right where you want it. So say you need to turn this an extra quarter turn. Well, now instead of your abutment coming out here, now your abutment comes out here. And that can create a problem for you. So by having a flat platform, it gives us a lot more options in placing our abutments, and we're not painted into a corner by having that one angulated platform. And so in these zygomatic implants, again, they're 4.2 millimeters in diameter. We have lengths of 30 to 60 millimeters. And what's also extremely nice with the NOR system is the amount of abutment selection. So for full arch cases, we have 0 degree, 17 degree, 30 degree, 45 degree, 52, 60 degree, a lot of abutment selection. And if you look at most of their implant companies in the full arch market, they only have 0, 17, and 30 degree abutment selections. And if you're doing enough of these cases, you have enough situations with bone angulations and no bone and minimal bone, and you find that there's many times that you do need a 45-degree abutment. You do need a 52-degree abutment, sometimes even a 60-degree abutment. And so with some of these other companies, when you don't have as wide of a selection, you end up with scenarios where your prosthesis has an access hole, significantly located towards the palate, or you may be facially located because you just don't have the abutment selection that you need to restore that particular implant. And then prosthetic component, there's a number of benefits that I've found with these prosthetics. I'd say most importantly for me, what we have found is I like these screws. These screws work very well. Some other implant companies that I had used in the past, we would have problems with screws stripping, problems with screws breaking. These screws especially are very nice, and also these transitional prosthetic copings are very nice. They're very sleek. They have good retention, and I can tell you that some other implant companies that I've worked with in the past, these transition copings were much too thick and were not really conducive to making a sleek restoration, just because they were very, very bulky. Okay, so I'm going to finish off this lecture with showing a case that I did just today. I literally finished this case, a few hours ago. And so this case was an old all-on-X style case, and the patient was needing treatment of the bottom arch. He had some recurrent decay in the molars. He had some decay in some of the other teeth. His dentist had offered him one treatment plan, and the patient did not want to go forward with that. And he, based on the treatment he got in the maxilla, he wanted to go ahead and do similar treatment in the mandible. Now, some updates to this patient. This patient had developed restless leg syndrome over the years. He had developed a pretty severe bruxing habit. And so in doing this case, what I did today was I added 2 pterygoid implants for a couple of reasons. One, I wanted to give this patient some extra support. Also, he asked and inquired at the beginning of the procedure, in the beginning of the process, if he could get an additional molar. He said if he could get one, he'd be, very happy about that. And to do that, we could add 2 pterygoids and extend the length of the restoration. And then in the mandible, placed 4 tough implants between the middle foramens, and then 2 6-millimeter implants, because I can tell you on the CAT scan, we had about 7 millimeters to the inferior alveolar nerve. And every time I look at one of these panos after a case, it always looks like you have so much more room to the nerve. But I can tell you that when you're measuring the CAT scan and you're looking at 7 millimeters to the nerve and you're in the case, you don't get any awards for getting as close to the nerve as possible. And you certainly will get some paperwork in the mail if you hit the nerve. So, if I can be a little bit more conservative and be away from that nerve, then I'm happy to do so. And I can tell you with these 6 millimeter implants on the Tough line, we were able to get significantly high torque. And ideally, I would have liked to have placed this implant a little bit further forward, but there was just a lot of bone missing in this area. We were not able to engage and get adequate torque there, so we had to go a little bit more posterior. But the 6 millimeter diameter implant was able to achieve very, very high amounts of torque. And if you look at these two implants in this particular case in the pterygoids, the difference on this side, we were able to engage a Terry Fit style implant here. Now on this side, at my first attempt in placing the implant, I got torque, but not quite as high of torque value as I wanted. So I ended up going to a larger diameter Tough implant. And when I used that larger diameter Tough implant, I was able to get a lot more insertion torque in the perimeter process of the palatine bone that I didn't get at my first attempt in placing the 4.2 millimeter Terry Fit implant. So because I had these options available and I had these implants in stock, I was able to get good insertion torque for both and load that portion of the case without worrying about having any problems. If I didn't have that variety of implant stock available to me, then it would have caused me some problems. And so here's the patient after the case. We can see we had pretty nice symmetry on our implants. And thought process, again, I wanted some extra support. The patient wanted the extra molar, and to do that, I needed some extra support. And then I was giving this patient 6 mandibular implants, and so I needed a little extra support in the maxilla as well. And by doing this, we're able to eliminate the cantilever and then support the Tough implants that were placed on the bottom. And so in summary, for everything we've covered today, we talked about case selection, case planning, breaking the all-on-X procedure down into steps, keeping your options open because you never know what type of curveballs are going to come your way when you're doing these procedures. And then to keep your options open, many times that can mean utilizing the right implant system, because certain implant systems are going to give you a lot more options and flexibilities than other systems. And I can tell you that from personal experience over the years, that the Nora system definitely gives you a significant amount of options with a implant design that is really specifically designed for an immediate load protocol and a full arch style protocol. And so in that concludes our lecture. I can't tell you that some of the information that we presented in the lecture today, I do have a textbook coming out later this summer. Information about this style of treatment and pterygoid style of implants is going to be in this textbook, and it's available at pterygoidimplantbook.com. And I'd like to thank everybody for attending the lecture and open the floor for any questions for anybody that's stayed through my long-winded lecture here. Again, thank you.